Hi, this is Elliot Fishman, and welcome to our September 2024 CTisus quiz. It's hard to imagine the summer is over and we're in September. Nevertheless, I have 10 terrific cases for you, so let's get started. The most likely diagnosis in this patient is, this is kind of a tricky case. It looks like you have lots of soft tissue masses involving the paraspinal region extending into the mesentery. They extend down into the pelvis on the coronal view, so they're very extensive. Also, you see masses in the right flank. What could this be? It's homogeneous and low density. You surely would think about lymphoma, but lymphoma is more soft tissue density. This is too low density. Testicular tumor can give you large cystic or solid nodes in the retroperitoneum, not this appearance, however. And this is really not carcinomatosis. It's infiltrating, it's extending downward, but not that type of carcinomatosis appearance. If you also look closer, you see there's widening of the spinal canal and there's artifact from hardware. This was a patient who has neurofibromatosis, and these are neurofibromas in the retroperitoneum, in the mesentery, in the paraortic region. Patients with neurofibromatosis can have really extensive neurofibromas and simulate malignancy. Of course, we need to be careful because neurofibromas can become malignant. Some patients with neurofibromatosis do have an increased incidence of that transition. In this patient with chronic abdominal pain, the most likely diagnosis is, what I see on the axials and coronal views is markedly thickened duodenum. It's kind of edematous, thickened. The rest of the abdomen looks good. There's no significant adenopathy. Lymphoma can involve small bowel and be infiltrative. Crohn's can involve small bowel, but not this kind of edematous type pattern. And amyloid usually is solidly infiltrating without thickened folds, but kind of a more extensive involvement, often with some type of mesenteric pathology as well. This was an infectious process. This was Giardia. I showed this case because Giardia infection does occur, and when it does occur, it's most commonly in jejunum. Remember, jejunum, think Giardia. Terminal ileum, you think infection, think salmonella. TB also was terminal ileum. Great case. In this patient with abdominal pain and diarrhea, the most likely diagnosis is, I see a mass and inflammation involving the terminal ileum and the cecum. There's some stretching of vessels present. Crohn's is a thought, but Crohn's usually is narrowing. This looks more mass-like, not the appearance of Crohn's. Giardiasis usually is really edematous folds, and as we know, it's most common in jejunum. Lymphoma can be bulky, so in some sense you could say, well, could this be lymphoma? TI and cecum, not a bad thought. There are a few nodes in the mesentery as well. This patient was young, the patient was worked up, and at the very end, this patient had salmonella infection. Salmonella can really be a difficult diagnosis unless you have a good history, like the patient was at a picnic and ate potato salad that was spoiled and 50 people are sick. Salmonella has often been reported large groups of people, but you can see it can be a group of one, can be inflammation, terminal ileum, even have adenopathy present, a very difficult diagnosis, but something to think about, particularly as summer goes to fall. It's a good summer diagnosis. The most likely diagnosis in this patient with a widened mediastinum on chest x-ray is, there's a large mass in the middle mediastinum. It's vascular with central low density. It could be lymphoma, though not the greatest location to only have that in lymphoma. Thymoma is anterior mediastinum, not a good place, and the same thing true for teratoma. Paragangliomas, which are really ectopic pheochromocytomas, they're neuroendocrine tumors, can be vascular, can have central necrosis, and the middle mediastinum is a good location for these tumors, and this was a paraganglioma. In this 30-ish-year-old with chest pain, the best diagnosis is When you look at this, you begin to try to figure out the pleural effusions, the consolidation, but then you look at the heart. What's that bulging coming anterior from the heart? And you can see on the sagittal view, it's really coming off the left ventricle. The left ventricle has this large bulge with a thin wall. Yes, you could think about an infarct, but with chronic infarcts, you see calcification, and acute infarcts, this is not the appearance. It's not the aorta, so it's not an aortic dissection, and it's left ventricle, not right ventricle. This is an outpouching. This was a pseudoaneurysm off the left ventricle in the patient who had a prior stab wound. Left ventricular pseudoaneurysms are rare, most commonly are related to trauma, and this was an excellent example. In this patient with hemoptysis, the most likely diagnosis is there's non-contrast scans in a patient who has an endovascular stent, and then you see the contrast scans, and then there's a very bright structure in the mid-left lung. When you track it, it goes toward the pulmonary artery. We're not dealing with lung cancer here, and we're not dealing with vascular lung mets. The enhancement of that structure in the left chest is the same as the aorta. It's not a plasmacytoma, obviously. It's a pulmonary artery pseudoaneurysm. Pulmonary artery pseudoaneurysms are rare. They can be due to drug abuse. They can be due to stab wounds. They can be post-operative in nature. This was a patient who actually had a history of IV drug abuse. That's what led to the stent in the aorta. And now you can see in the post-op period a pulmonary artery pseudoaneurysm. The most likely diagnosis in this case is, well, when you look at the patient's ascending aorta on coronal especially, but also on the axial, you see what looks like about a 7 millimeter low-density lesion, and perhaps it's a thrombus. It's a good thing to think about. It's not flow-related, and it's not bulky enough to be lymphoma, and you don't see lymphoma typically intraluminal. When you see this lesion, you're thinking about thrombus, but also a papillary fibroelastoma, which is a common benign lesion that needs to be resected because it gives emboli. When you look at the aortic valve, when it's inside the valve, looking toward and into the patient's left ventricle, then it's a thrombus. When it's coming off the valve leaflets, but going upward into the ascending aorta, it's a papillary fibroelastoma, and that's what the diagnosis was. In this patient with HIV, the most likely diagnosis is, what do I see here? Multiple nodules, variable sizes. Some of them have a very hazy edge. This could be septic emboli. It could be lung metastasis if the patient had a choriocarcinoma, for example, or several other tumors. Kaposi sarcoma is a good thought as well. In this case, another possibility is B-cell lymphoma. B-cell lymphoma can involve the lung primarily or secondarily, can have multiple lesions. Now, this is probably an unfair case, and if you said septic emboli, I'd probably give you credit. If you said lung mets, I guess it could be. And Kaposi's is not a bad thought, and I told you HIV, so you'd be thinking Kaposi's. But this was a B-cell lymphoma, a very difficult diagnosis, and perhaps it's a case where all of these need to be thought about, and then something ends up being biopsied. But there's an increased incidence of B-cell lymphoma in patients who are immunosuppressed, and so patients who are HIV fit perfectly in that category. In this patient post-C-section with fever, what's the most likely diagnosis? Post-C-section, you worry about bleed, you worry about injury to the uterus, you worry about changes in the abdominal wall, and bleed can be anywhere from the uterus to around the bladder to the abdominal wall from the inferior epigastric arteries. You also worry about bladder injury. What you see here is on the axials, there's a mottled appearance density present, which is outside the uterus on the coronal views. And this was a really, really good example. It's at first thought may be an abscess, but it's well defined, funny location, but could be an abscess. It's not really the look of a perforated uterus. The uterus looks okay, and it's not a bleed. What this is was a retained sponge. Again, even in this era where we're so careful looking at counts, retained sponges do occur, and this was one example. The most likely diagnosis in this case, there's a large mass, about 5 centimeters, slightly vascular. Hard to tell where it is on the axial. On the coronal, it's easier to see that it's coming off at the junction of the ligament of Treitz. It's coming off duodenum and proximal jejunum. It could be lymphoma. They can be somewhat exophytic, but it's a bit too vascular. Adeno are usually not exophytic. They're more infiltrating. And similarly, metastases are more likely infiltrating, but we know Mets, particularly melanoma, can look like anything. Because of the vascularity and the exophytic nature of this tumor, we thought about a neuroendocrine tumor, and in fact, this was a neuroendocrine tumor, primary in the duodenum. There's no mesenteric masses. There's no other findings. So neuroendocrine tumor was the best diagnosis in this case. Well, those are 10 wonderful cases. I hope you got them right. Some of them were indeed very challenging. Some of them I even couldn't give you a perfect answer. But anyway, we're in the learning process, and I hope that helped you. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.